Hello, and welcome to the Public Health Shift audio edition. I'm Nadia. In this space, I read and reflect on each issue of my newsletter, creating a pause for public health professionals to think more deeply about how we work, what we prioritize, and what the current moment is asking of us. This episode is based on issue 28. Why must systems adapt, but innovations don't? Over the years, I've been involved in many conversations about innovation in public health. Whether the discussion is about digital health, artificial intelligence, healthcare financing, new service delivery models, or other emerging approaches, there is often a shared sense of optimism about what these innovations might make possible. Many of these solutions are backed by strong evidence, and they are supported by reputable institutions, developed by talented teams, and designed to address genuine health system challenges. Yet, despite their promise, a surprising number struggle to move beyond the pilot phase or to become fully integrated into the system they were intended to strengthen. When this happens, the explanations often sound familiar. We hear that adoption was slower than expected, that capacity was insufficient, that implementation faced resistance, or that the system simply was not ready. The more I reflect on these explanations, the more I find myself wondering about an assumption that sits beneath them. In many cases, the starting point of the conversation is the innovation itself. The intervention is introduced, its benefits are explained, and attention quickly turns to the question of implementation. The challenge then becomes understanding how the system can adapt in order to accommodate this new approach. But what receives less attention is the possibility that implementation challenges may not only be revealing limitations within the system, they may also be revealing a mismatch between the intervention and the environment in which it's being introduced. And this raises an interesting question. Why do we spend so much time assessing whether systems are ready for interventions and comparatively little time assessing whether interventions are ready for systems? The more I think about it, the more I notice how much of our language around innovation reflects a particular way of thinking about change. We talk about scaling innovations, accelerating adoption, overcoming resistance, and preparing systems for transformation. Implicit within many of these discussions is the idea that innovation represents progress, while the system represents a barrier that must be overcome. To some extent, this perspective is understandable because health systems are complex, resource constrained, and often operate under considerable pressure. So introducing change is rarely straightforward. However, I sometimes wonder whether this framing influences where we look when implementation becomes difficult. If uptake is slow, we often look at the workforce. If an intervention struggles to scale, the discussion tends to focus on governance, capacity, or financing. If outcomes fall short of expectations, attention frequently turns to whether the system was ready. Far less frequently do we ask whether the intervention itself was sufficiently adapted to the realities of the system. One of the concepts that has been on my mind recently is the idea of fit. In public health, we often focus on whether the intervention will work. We examine the evidence, we assess its effectiveness, and consider whether the approach has demonstrated positive results elsewhere. These are important questions, but at the same time, effectiveness and fit are not necessarily the same thing. An intervention may be technically sound and supported by strong evidence, may be implemented exactly as intended, and yet it may still struggle. And that could happen if it does not align with existing workflows, incentives, financing arrangements, decision making processes, or organizational realities. And this is perhaps one reason why interventions that perform well under pilot conditions sometimes encounter difficulties when they move into routine implementation. Because the challenge is not necessarily that the evidence was wrong, but rather that the evidence alone can't tell us whether an intervention belongs within a particular context. And as I reflected on this issue, I found myself returning to a term that appears frequently across public health discussions, the term of system readiness. Systems are often described as being ready or not ready for digital transformation, for artificial intelligence, innovative financing mechanisms, or new service delivery models. In many cases, these assessments are valid. The success of any intervention is indeed influenced by factors such as institutional capacity, financing, governance arrangements, workforce availability, and infrastructure. But increasingly, I wonder whether the concept of readiness sometimes defines how implementation challenges are interpreted. When an intervention struggles to gain traction, the conversation often focuses on what the system lacks. The discussion naturally turns to capacity gaps, institutional weaknesses, limitations of the workforce, and barriers to adoption. Less attention is often given to whether the intervention itself aligns with the realities of the environment in which it's being introduced. Questions about fit, adaptation, and contextual relevance can become secondary to questions about uptake and implementation. And this may seem like a subtle distinction, but I think it has very important implications. Because if implementation challenges are viewed primarily as evidence of system weakness, then the efforts to address those challenges will naturally focus on changing the system. If those same challenges are viewed as signals that an intervention may require adaptation, then a different set of questions will emerge. To what extent does the intervention reflect existing workflows or decision making processes? How well does it align with current incentives and financing arrangements? What assumptions were made during its design about how the system operates? Which aspects of the intervention are essential and which could be adapted without compromising effectiveness? The more I reflect on this, the more I think that successful implementation often requires both systems and interventions to evolve together. Earlier in my career, I witnessed the creation of MTBA, a healthcare financing platform that is often described as an innovative solution. Looking back, what I find most interesting about that experience is not simply the platform itself, but the fact that it emerged within an environment where many of the underlying conditions for adoption already existed. M-Pesa had already transformed how millions of people in Kenya managed money through their phones. The infrastructure was already there, and the behaviors were already established. Perhaps most importantly, the trust already existed. Rather than requiring people to adopt an entirely unfamiliar way of interacting with financial services, the platform built upon patterns that had already become part of everyday life. The experience left me wondering whether innovation discussions sometimes begin in the wrong place. Much of the conversation focuses on identifying new solutions. Yet, in many settings, the more important starting point may be understanding existing capabilities, behaviors, incentives, and sources of trust, because these factors often receive less attention than the intervention itself, despite playing a significant role in determining whether an innovation ultimately succeeds. The distinction may seem subtle, but it can lead to very different conversations. In one case, the starting point is the intervention itself, and the challenge becomes how to facilitate its adoption. In the other, the starting point is understanding how the system currently functions and identifying what prevents existing approaches from performing as intended. One of the observations that has stayed with me throughout my career is that many public health challenges do not necessarily stem from the absence of solutions. In many cases, we already know what works. We know how to improve vaccination coverage. We know how to strengthen disease surveillance. We know how to reduce maternal and child mortality. We know how to deliver many highly effective public health interventions. The difficulty often lies in sustaining implementation, in coordinating actors, securing financing, building trust, strengthening accountability, and ensuring that interventions continue to function long after initial enthusiasm has faded. This is why I sometimes wonder whether discussions about innovation can inadvertently distract from a different challenge: understanding systems well enough to design interventions that fit them. None of this should be interpreted as an argument against innovation. Public health has benefited enormously from technological advances, new delivery models, and creative approaches to long-standing challenges. Rather, it's a reflection on where innovation discussions begin and how implementation challenges are interpreted when they emerge. And perhaps that leaves us with a few questions to reflect on in our own work. When implementation becomes difficult, where do you instinctively locate the problem? Within the system or within the intervention? How often do discussions focus on system readiness compared with intervention readiness? What existing capabilities, behaviors, or sources of trust could new initiatives build upon rather than replace? And how might program design change if understanding the system came before selecting the solution? Thank you for listening. If you would like to continue the reflection, you can read the full version of this issue by subscribing to the Public Health Shift newsletter on www.nadiatekal.com. Until next time, take care and keep questioning how we show up in our work.